she's actually in a narrowing phase here, which is just she likes to be in extension more so than flexion, the cranial system. So I'm going to follow those two together. Narrowing phase. When it gets to its narrowest phase, I'm going to lock it in, induce a still point by preventing the widening sensation. Just freezing my hand in and holding. Waiting for a still point, inducing that still point, waiting for the motion to begin again. That's our craniosacral balancing. Now, if you do quite a bit of craniosacral work on patients, especially if you are not sure of what you're doing just yet, it's easy to imbalance them by putting tension across membranes, and sometimes people feel a little off balance, kind of like saying, gee, I stretched one half the patient's body but not the other half. How do they feel now that they get up and walk around? They feel a little off kilter. So if you finish a craniosacral session with a craniosacral balancing, you balance that out. So they don't feel weird. Some people feel a little flighty or a little foggy. When they first get up, they're all relaxed. They're used to being in high tension state. So this is a nice way to get them kind of grounded and have them breathe, relax. It's a nice way to do it. I could do this in sideline. Picture in your book is shown in sideline. I've done it on patients in sitting plenty of times. Supine, but they tend to crunch your hands a little bit in the supine position. It's certainly an option. So let's go ahead and check out the sacrum motions on our partner. Let's check out the cranium separately, the occiput, and then the two together. See if you could balance out your partners, and we'll talk a little bit about the research. On lateral epicondylitis, one of the same researchers with a different partner this time, Norbekash and Fearon, effective oscillating energy manual therapy on lateral epicondylitis, another randomized, double-blinded, placebo-controlled studies. Okay, Journal of Hand Therapy, this is from '08. They looked at different variables, pain, grip strength, and functional abilities of people with that chronic lateral epicondylitis, that tennis elbow. A number of subjects is 23 with chronic lateral epicondylitis, LE, greater than 3 months, ages 24 to 72. They did 6 sessions. This is very typical of what we're seeing with managed care today. Oh, Oxford allowed you 6 sessions to treat that rotator cuff repair. You're getting a very limited deal when it comes to interaction with your patients. Randomized into a treatment and a control group, and they tested pre and post treatment, and they also tested their outcome 6 months later. Because one of the common questions is, okay, gee, they felt good now, but what's the carryover? Did you see any carryover? Statistically significant improvement in grip strength, so using like a JMAR hand grip dynamometer, and I gave you the P level, 0.03, pain intensity, function, and also limited activity due to pain. So they looked at a number of functional scales, and very nice to see the difference. This, of course, they were doing the same what they call the V-spread technique, inducing a still point, but this time it was over the lateral epicondyle. The placebo was actually to put the hands in the same position, but they weren't inducing any still points. So very different in terms of the intention. What happened later? 91% maintained their improvement in function. Now, I don't often see that with something as chronic as lateral epicondylitis. People go out doing the same gripping, doing things the wrong way, repeating their irritation. 73% remained pain-free for at least 6 months. And I gave you some links where you could access this. These are all published through the Fascia Research Congress. CranioSacral Therapy helping fibromyalgia pain. Here's an issue where people with fibromyalgia have a lot of trouble, and we often find we're not very adept at treating this. Castro-Sanchez et al. Did a randomized control trial. Again, we're looking at good levels of clinical research, not just case reports. Effects of craniosacral on pain and heart rate variability. Interesting what's happening with the sympathetic nervous system in fibromyalgia patients. A Clinical Rehabilitation Journal, 2011. So these are pretty recent. 92 patients with FMS, fibromyalgia syndrome, randomized, treatment and placebo. They had 20 weeks. Now, I don't see any insurance company giving anybody 20 weeks of therapy these days. But wow, that was pretty good of craniosacral therapy. They measured heart rate variability, which is using Holter monitor and blood pressure. And pain levels, what do we get? Statistically significant difference in pain, okay, in 13 out of 18 of their trigger points. Now, typically, one of the definitions for fibromyalgia is that they have pain in at least 11 of 18 trigger points. Here they got 13 of them improved in their pain difference. Here's your p-value. And one of the measures of heart rate variability, temporal standard deviation, okay, that's a bunch of stuff. Basically said the sympathetic system responded better. Okay, they also did a clinical global impression of improvement versus baseline. They did another follow-up also at 2 months and 12 months. Continued significant difference with the treatment group. Here's another study looking at CranioSacral Therapy alters cranial membrane length. And this is Dr. Dimitrios Kostopoulos. He's actually a physical therapist in my area of Queens, right in the area where I grew up. He studied changes in elongation of the dural membranes of the brain. Naturally, this is done in cadavers during application of some of these craniosacral therapy techniques. So they used embalmed cadavers and they measured with strain gauges. What's the elongation of the falx cerebri? Okay, there's different releases that you do for each of these falx cerebri, falx cerebelli. We didn't go over each of these, but there's more techniques you could learn taking other cranial courses. How much motion? 1.4 millimeters for the frontal lift. Oh, look, we did that. 1.08 millimeters for the parietal lift. So you can actually measure the movement of the actual cranial membranes. And this was done here. Sphenobasilar compression. Oh, we did that. Minus 3.3. What are we doing? Taking the pressure off. So it's a negative. Sphenobasilar decompression, 0.28 millimeters. Okay, so not a lot of movement there, but measurable movement. Very interesting. For the ear pull, they didn't get conclusive results. I don't really know why. Okay, and present study offers validation for the scientific basis of craniosacral therapy, which is that we are claiming we're removing these membranes to adjust tension in the membranes. And here he's actually measured that movement. This is in the journal Cranio. Repetitive motion strain. This is modeled in a lab. They're not using people, they're using cells that build fascia. So Meltzer et al. Is doing a lot of studies with modeled repetitive motion strain in vitro, so in a lab with myofascial release using human fibroblast cultures. And they submitted these cultures to different levels of strain. 3 groups, 8 hours of repetitive motion strain alone, myofascial release for 60 seconds. Interesting, they did 60 because most of us have been doing for 60 years or so in the field, 90. And then a combination, repetitive motion strain and myofascial. What's the results? Due to strain, there's immediate change in the cell shape and structure, morphological changes that can be noted as a result of repetitive strain. What are those changes? Increased apoptosis rates. What does that mean? They die sooner. How do you know? Because there's certain chemicals produced by cells that are being strained repetitively in response to that trauma. FAK, focal adhesion kinase. That's a chemical related to, remember we said things stick together? Collagen cross-links? FAK. DAPK, this sounds nasty, death-associated protein kinase signaling. Cells are dying sooner when they're subjected to repetitive strain. Guess what? This was not seen in the group that had myofascial release, and even more interesting, not seen in the group that had repetitive strain, but was also treated with myofascial release for a mere 60 seconds. You didn't see those cells die as readily. So this is very interesting stuff. This is Journal of Bodywork and Movement Therapy. Paul did a special type of high-resolution, high-frequency ultrasound, and went subcutaneously to see, in 10 cases, what happens when you compare a normal area, in this case of the back, to a restricted area. Well, the restricted areas show up as increased hypoecho on the ultrasound, and increased density. Looks like white, thick, dense tissue on the ultrasound. After they did myofascial release, skin rolling, skin pressing, basically taking up the slack and holding, change of collagen density, okay, reduced the dermal densifications, and relaxed, or again, changed the shape of the fibroblast. We noticed from the other study that we said there's a morphological change in the fibroblast where they got stretched out, they became abnormal in their cell shape, and cells can't function in an abnormal shape. This normalized some of the very cells that build fascia. Crane took a bunch of crazy athletes and said, let's really see what we could do about wrecking your quads. And they had them do isokinetics. Work those quads, work those quads. And they did a nice biopsy of the vastus lateralis before and after to see what kind of problems happen when we induce exercise in the muscles, what kind of damage happens. And then can we take 2 different situations, massage one group of these people doing heavy exercise, and have a control group that doesn't get anything. So 11 males volunteered to biopsy the vastus lateralis at rest, and then they checked it also immediately after massage for 10 minutes worth of time, and 2.5 hours later after exercise. What did they find? No effect on lactate and glycogen. And we always hear these studies how, oh, the lactate, the lactic acid, that's what's making you sore. But they're not seeing any change in that, which is interesting. But what did they see change? Inflammatory cytokines were reduced in the group that got massage or myofascial release. What are those inflammatory cytokines they measured? Tumor necrosis factor alpha, interleukin 6, and HSP27. I mentioned again in review, those acupuncture meridians the areas of the fascial planes of the body, where one layer of fascia meets another, those layers need to glide past each other. If they have abnormal tension, myofascial restriction, sticks together. We call that collagen crosslinks. What do these people do? They measured electrical impedance in 28 healthy people across the skin and subcutaneously and found a positive correlation between the fascial planes of the body having changes of electrical conduction and the acupuncture channels. And fascial planes have a very high correlation with where the acupuncture channels or connecting the dots of those acupuncture meridians are.